Our global forum brings together regional experts to discuss tropical infections, novel therapeutics in diabetes, and the role of AI in healthcare. I am pleased to introduce the chairpersons, Dr. Suranga Manilgama and Dr. Madhuanti Hettiarachchi.
Good morning, everyone. Today, Global Forum, there'll be three speakers talking, and the first talk is by Dr. Amit Saraf, MD, FRCP, FICP, FACP, and FCPS. He's a Director, Department of Internal Medicine, Jupiter Hospital, Mumbai, and he'll be talking to us on unmasking melioidosis. Over to you.
Thank you, Chairpersons. I think to start the Global Forum, it's very appropriate that you begin by saying the Sri Lankan way of Ayoban, I hope I'm right, or Vadakkam, I think whichever language it comes from either, I think, the Sri Lankan or the Tamil. I also thank the organizers of the SIMCON for calling me here for this Global Forum. I represent the Association of Physicians of India from Mumbai. And the topic at hand we are talking today is melioidosis, extremely pertinent, extremely relevant to the part of the country we all stay, the Southeast Asia. Begin my session with this strange little diagram. You know, it's a mud pipe, a smoking hookah, as they used to call it in the previous days. And everywhere in the Southeast Asia, once upon a time, it was very pertinent. People used to smoke it. And the reason being this slide, that from the year 1910 to almost 2014, they found that endemic hotspots for melioidosis belonged unfortunately to our part of the world. And because those hookah pipes once upon a time were purely made out of mud, and as we go through my slides, we'll realize that this organism has a predilection to be in the mud. And inoculation is to happen to people who used to walk on bare feet on the wet mud, or at times smoke a hookah made from mud. That's how the inoculation is to happen, and that's how the transmission is to happen. That's the reason once upon a time these mud hookahs were extremely common and caused a lot of transmission of melioidosis. That's the reason for that particular slide. Now, what exactly happens? What's the pathogenesis of this organism? It's either a percutaneous inoculation, it's either an ingestion, or it can be an inhaled inoculation. It comes and resides within the human body. Depending upon the host immunity and the inoculum dose or the size of the inoculum, it will either remain dormant, or it may cause an active infection there and then, or it can be activated in the time to come. If it becomes activated in the time to come, it causes the bacteremia, sometimes the septicemia, or a latent infection, or any organ if it sort of latches onto the spleen, the kidney, the lungs, as we shall see a couple of cases I have to present, and that leads to a reactivation of a latent focus causing an active melioidosis patient. So I have got three cases lined up here. Interesting cases. If you be with me for the next 15-20 minutes, you'll realize how varied a presentation this organism has. When I was crafting this session, I realized, a lot of subject experts are there in the audience. It's an endemic disease for our part of the world. So rather than discussing the pathogenesis and the treatment, which we're all aware, I just thought, being clinicians and everybody is a clinician here, I thought, how can it fox us at times? How can it fool us as clinicians and cause varied presentations? So the first case, a gentleman of 67 years, came from Goa, western coastal city in India, and he had fever of 6 days, mild increase in frequency, urination from 6 days. The fever was high grade, accompanied by chills, no diurnal variation. Initially, he was given antipyretics, but the fever persisted. They did a blood count, which was normal. They did a sonography, which was normal. They did a blood culture, and that grew this organism, the Burkhoff-Deria cepacia. And then everybody thought, that's it. I'm sure trimethoprim, sulfamethoxazole, the Septran as we call it, was given to this patient as well, because it's sensitive mostly to that antibiotic. And he responded. And everybody thought that the case is over, patient is fine, he can go home. 7 days back, he again had temperature. And this time again, the moment the Septran was stopped, the fever came back. And this time slightly raised white cell count of around 12,000 with a slight neutrophilia, creat of 3 and A1C incidentally of 7.8. This gentleman was not a diabetic. These are all patients from my hospital in Mumbai where I practice. We are a tertiary care center, so we get referrals from many other parts. So this time around we sent 3 blood cultures. Let's be more sort of persistent. So 3 blood cultures were sent, a CT of the abdomen was done, and there was a history this time when, and in fact, surprisingly, my junior most resident asked him in detail what exactly happened. And the speaker prior to me said that, history is the diagnostic tool. And here in the junior most resident got the most relevant bit of history that he had walked on a beach close to his home, bare feet in the wet soil. So what did the CT show us? It showed a bilateral perinephric stranding. The blood culture started to grow some GNB at that point in time. We were still not very clear. So to give you a gist of the case so far, elderly gentleman, incidental diabetic, had uncontrolled diabetes by the time we diagnosed him. Acute on chronic renal failure, as it seemed. The first time around the creat was okay. The second time around it rose up. GNB bacteremia, blood culture done earlier showed Burkholderia cephacea, and he responded well to Septran. And then what? So we thought of this. So could it be urinary tract infection, pyelonephritis? It fit the bill of GNB bacteremia. It fit the bill of perinephric stranding. Didn't fit the fact that Burkholderia was grown on the first day. Diabetes can be a predisposing factor, and response to Septran also. So the first bit was there, but except for the blood culture growth in the first sample rather. Can it be Burkholderia cephacea with a UTI causing bacteremia? Could be, but then the GNB growth didn't support it. The response to Septran, yes, could be there. And then we thought of melioidosis. Could it be that? Because it fit the bill in all the aspects. All the check boxes were ticked when it came to melioidosis. And by the third culture, we got this. But before that, the point here was Burkholderia cephacea has been a contaminant in povidone iodine, and most of our nurses and even the phlebotomists, when they sort of they swab the area to do a venipuncture, they mostly use these betadine, the povidone iodine solutions. And most of the bottles sometimes have a contaminant of the Burkholderia cephacea, and that's how it grows in that blood culture. By that time, the day 3, third culture sample had come back from our laboratory, and they established a diagnosis of Burkholderia pseudomallei. And then the patient went on a Septran high dose, along with the IV ceftazidime. The diagnosis of melioidosis septicemic form was confirmed, and the patient improved, but he required a treatment for almost 6 to 12 months in the time to come. So lesson from this case was, it can be Burkholderia pseudomallei can be misidentified as some other organism, because the previous automated blood culture systems like the Vitek, the Bitek used to have a lot of misidentification within cross species. So Burkholderia cephacea coming as pseudomallei, not to mention that the cephacea can be a contaminant of povidone iodine, sometimes Pseudomonas, Acinetobacter and related species come in. Also remember that Burkholderia cephacea is an uncommon cause of community-acquired syndromes, and we should be viewed with suspicion. So though you grow an organism on the day first culture, if it's not fitting your clinical picture, you should be a little suspicious. How do you differentiate? So typically the colony morphology, which I will show this slide, where the double zone of susceptibility is seen for Septran is not seen in the other. So that's a clue there. And any susceptibility to amoxiclav but a resistant pattern to colistin may be a hint that the organism identified maybe as a Pseudomonas or Acinetobacter could be something else. So these are a few clues in that case. Second case. This time, a gentleman, middle age, 43 years, alcohol abuser, uncontrolled diabetic. So a different spectrum of scenario. Chronic pancreatitis in the past, and this time again came with fever of 20 days and a cough of 20 days. Fever was sudden in onset, high grade, accompanied by chills and rigors, no diurnal pattern, cough was scanty, mucoid, with few expectoration, not much of hemoptysis. He gave a history of, again, travel to the west coast, the coastal beaches of Goa a year back. Investigations had a bit leukocytosis with a bit of neutrophilia. Given outside the hospital before he came to us, somebody gave clarithromycin, levofloxacin, right choice of drugs, but unfortunately no response. Sputum culture that time grew Enterobacter cloacae, and somebody did a CT chest outside and showed consolidates in the right lung and a coarse ecotexture of the liver. With that, he came to us. So by the time he came, everybody thought probably tuberculosis, not responding to bacterial antibiotics, sorry. So let's think of tuberculosis. So we send specimen for gene expert, bacterial culture, the TB MGIT test. Surprisingly, a pulmonary form of melioidosis came through the blood cultures. And as always, the patient was again put on IV ceftazidime and Septran, and he responded with discharge being to abstain from alcohol and to control his sugars. But the point being, why does a tuberculosis and a melioidosis, pulmonary melioidosis, mimic each other? Look at the similarities. Both can have risk factors of uncontrolled diabetes, alcoholism, sometimes steroids. Both check tick all these check boxes. Both can cause a subacute to chronic community-acquired pneumonia, and both have a predilection for upper lobes, intracellular organism, and both need a prolonged treatment. So those are the similarities. And how do we differentiate them? Remember our old teaching days where we were taught that tuberculosis will have a low-grade temperature and an evening rise. On the other hand, melioid can have a high-grade temperature. So one differentiating point. The second being, tuberculosis mostly will have normal count, some kind of lymphocytosis at the most. Whereas in the first case you saw, and even the second case that we saw, melioidosis usually has a neutrophilic predilection and slight amount of leukocytosis. There is no response to antibiotic on the tuberculosis front, but this will respond to third generation cephalosporin, sometimes even fluoroquinolones. Consolidated and cavitary lesions are much common in tuberculosis, whereas multifocal nodules with coalesce with bilateral interstitial pattern is known in melioidosis. No such seasonal variation in seen is tuberculosis, but when we come to the further slide, we will see a typical monsoon variability in the melioidosis, and why also we shall see. So clues in this case were vis-a-vis tuberculosis. He had high-grade temperature, he had high counts, he traveled to an endemic area, and there were nodular coalescing opacities. The enterobacter growth, if you remember, which came in the first blood culture, was likely a colonizer and not a common cause of the community-acquired pneumonia. This lady, Professor Vidyalakshmi, I'm so sorry, had a publication in the Indian JAPI, the Indian Journal of Association of Physicians of India, and she had 22 cases, all sort of looking as tuberculosis. All of them came as melioidosis. And look at the presentation. Out of those 22, 8 mimicked pulmonary tuberculosis, 5 mimicked tubercular arthritis, 3 looked like tubercular spondylosis, 2 looked like tubercular lymphadenitis, 2 were splenic abscesses, and 1 of them each mimicked a tuberculous pericarditis and a parotid abscess, and all of them turned out to be melioidosis. And they concluded that the clue was in the neutrophilic leukocytosis. Otherwise, most of the pattern they found was very similar in both the presentations, but that neutrophilic leukocytosis, so that's a very important take-home message here. Coming to the seasonal variation, why July, why the monsoon? So we all belong to Southeast Asian continent, and we know that we have a typical monsoon from that June to September bracket in India and Sri Lanka as well. And what happens during that bracket? So if you see the bars are the monsoon, the black line is the cases for melioidosis. And typically as the bars rise during monsoon time, the heavier rain comes in, more the case load of melioidosis rises because the organisms thrive much more in a wet mud as compared to the dry soil. My last case for this morning, 61-year-old gentleman, alcoholic since 40 years, ischemic heart disease, post a CABG, post a PTCA, resident of Mumbai, came from the coastal belt of Maharashtra, went to his village, came back to Bombay. He has chief complaints of fever with chills for 40 days, left-sided chest pain for 40 days. So this presentation is more chronic. The first case we saw was acute, second maybe acute on chronic, maybe of that pattern, a middle pattern. This was much more of a chronic presentation. This gentleman had insidious onset of temperature, intermittent in type, associated with evening rise, initially low grade, which then progressed on to high grade, associated with chills, weight loss of almost 14 kilograms, and night sweats as well. We did a workup, he came to us, we got the counts, it was leukocytosis, 15,000 plus, neutrophilia as well. X-ray showed a little right upper zone infiltrate, and incidentally he was diagnosed as diabetic as well. As usual practice, he was put on cefotaxime and cefixime for a total of 10-12 days. Partial response to this treatment in the form of defervescence. Fever came back in a few days' time, and that's where he was with us after that antibiotic course. A CT was done, and we saw a right upper zone consolidation with early cavitation, mediastinal adenopathy, multiple hypodense lesions in the spleen. It's completely foxed us. We were not expecting a splenic deposit or a lesion at all, of varying size of microabscesses. And then again, melioidosis fit the bill because we thought of tuberculosis to begin, but then it wasn't falling in the line of having a high white cell count and responding to a third generation cephalosporin. Lymphomas again can't have a right upper zone consolidate, can't be responsive to third generation cephalosporins. Infective endocarditis as well not. So melioidosis ticked all the check boxes of right upper zone consolidate, splenic deposits, and a partial or a high response to third generation cephalosporins. So on that, we did a CT-guided FNSE. There was a neutrophilic predominant infiltrate aspirated. Culture was sent, and lo alas, it turned out to be Burkhardia pseudomallei. Again, this gentleman was put on a 2-gram 8-hourly of ceftazidime intravenous and a double dose of trimethopyrin sulfacetamide, which is 180 and 800 milligrams for almost a week in the hospital, and further on after he went home. Incidentally, in the hospital, he developed an ankle joint swelling, and we thought now what that could be, is it something else? We did the joint aspirate, and that also grew Burkhardia pseudomallei. So the same treatment continued. He was discharged, planned for 6 weeks of therapy, and he followed up, and a total of a year's therapy went by, and he was absolutely okay at the end of it. So what did we learn from these 3 cases? Melioidosis, in the first case, presented as septicemia. In the second case, came up as a subacute necrotizing community-acquired pneumonia. And the third case, it showed a PO-like picture, 40 days of temperature, with a lung consolidation and a splenic abscess. So look at the varied features. And why such varied features? Why can't it be a straightforward case like most of the other organisms like malaria, dengue, tuberculosis, which have a very traditional, typical presentation? So for that, incidentally, since I was coming this year, I found a paper published from Sri Lanka in the American Journal of Tropical Medicine and Hygiene, which studied the clinical, bacteriological, geographical stratification of melioidosis, emerges from the Sri Lankan National Surveillance Program, and they found that certain multi-locus sequence types were correlated with certain clinical presentations. In other words, certain serotypes of this melioidosis, certain had a predilection towards the lung or the spleen or the joint at times or a septicemia at times. What can be the differential? We're talking about melioidosis, but yes, can we think of something else? So if it's an acute pneumonia, obviously community-acquired pneumonia becomes a differential. If it's an acute sepsis, think of bacterial septicemia. If you see liver and spleen abscesses, microabscesses, you can think of dimorphic fungi, tuberculosis, lymphoma at times. Parotitis presentation can be mumps. If it's a chronic pneumonia, then tuberculosis, nocardia, NTM, or aspergillosis can be the differentials to melioidosis. Last couple of slides. This is a aromatherapy spray, which we use as room fresheners in our homes, our offices. And there was an outbreak of melioidosis after the use of this in the United States. This was a journal article published in the NEJM in the year 2022, where a group of families living in the same locality, somebody recommended this spray, was brought from an endemic, I think a Southeast Asian country. She recommended to a neighbor, and the neighbor recommended somebody else. And suddenly that they had a mini outbreak there of everybody having this. So they realized that sometimes even the aerosol contamination of melioidosis can lead to a small little outbreak. So to end, ladies and gentlemen, my take-home messages for all of you are: Burkhardia pseudomallei can present as bacteremia and or septicemia, community-acquired pneumonia. It can come across as a pyrexia of unknown origin with lung consolidation and a splenic abscesses. Sometimes aerosol use from endemic, especially brought from endemic areas, can also cause it. So how do you then diagnose it, treat it, be aware of it? It's an existent entity in especially our part of the world, and be vigilant for it. 2 important take-home messages. Thank you so much for a patient hearing.
Thank you very much for that interesting lecture. And I think we'll ask the questions at the end of the symposium. If you can come and please take a seat here.
Let's move into the second talk of the symposium. We all know this Global Forum Symposium had been there for 3 years. This is the third year we are having the Global Forum. So we will be combining with our neighboring countries, India, Nepal, and Bangladesh. Next speaker will be is from Nepal. So he's Professor Ratnamani Gajurel, and he's MBBS MD, internal medicine, DM, TU, IOM, Nepal, from Nepal. And he's a specialist in internal medicine and cardiology, and he's the president to Society of Internal Medicine of Nepal. It's over to you, Dr. Gajurel.
Thank you. Thank you, Chairperson. First of all, I want to give thanks on behalf of my society and as a president of Society for Internal Medicine of Nepal to represent in this global forum that is organized by Sri Lanka College of Internal Medicine. As I've just came to know that this is the third year the college is conducting this sort of global forum, and this will definitely give the chance to the Neo Society to come and have a friendship with another sister society. Thank you, all the organizer and the college member of the Sri Lankan College of, council member of the Sri Lankan College of Internal Medicine. Without having said this, I want to start my presentation. All of you know Nepal is the very small country in Southeast Asia, and we claim ourselves at the top of the world because we have the highest mountain. And our culture is different, and we also say that we are from the country of the Buddha, where Buddha was born. So accept my gratitude. And the topics today assigned for me in this global forum is the novel therapeutics in diabetes. I will be focusing more on the novel therapy in diabetics. Having said this, the old is always gold. The previous therapy in diabetes management is equally important. I don't have any conflict of interest regarding my presentation. When we see the epidemiology of the diabetes, about 550 million adults are living with diabetes in the world. Every 3 in 4 adults with diabetes live in low to middle income countries. The high income countries, the rate of diabetes is going down. And when we see the old data, 6.7 million deaths due to diabetes in 2021. So as we all know, diabetes has a very high risk global health problem. When you see the prevalence of diabetes in the different continent, the most highest is in the North Africa, Middle East, and Latin America and Caribbean. This means we are not safe. Now, the Southeast Asia is becoming one of the main hub of the diabetes. And it is said that one day the Southeast Asia will be the capital of diabetes. When we talk about the type 1 and type 2 diabetes, which is common, type 2 diabetes is definitely common because in our part of the world, type 2 is more common in comparison to type 1. When we look at the burden of the disease worldwide, in 1990, global age standard prevalence was around 3%. In 2021, it became double, 6. And the expected increase in 2050 is 9.5. That means 61.2% increases from 2021. So the burden of the disease will be increasing. The another fact we should know is in every 10 seconds, among us, 2 people will develop diabetes. So we can estimate the risks and the gravity of the disease. When we see the data from the different countries, Like India, China, the Asian country, they have high population and the rate of increased diabetes is also high. When we see the prevalence of diabetes in South Asian country only, the most prevalent in the Pakistan, followed by Sri Lanka. Then the day before yesterday in the oration also, I have seen that the Sri Lanka is also one of the hub of diabetes. In Nepal and Bangladesh, in comparison to other countries, it is less. This is the data, the article published in the BMJ. The prevalence of diabetes and pre-diabetes in Sri Lanka, a new global hotspot, estimates from the Sri Lanka Health and Aging Survey 2018 and 19, said that the Sri Lanka the diabetes is going up. It is in the previous estimate, it was 8 to 15%. Now it is higher than that. When you talk about briefly the physiology of glucose regulation, I am not going to go in detail. There are multifactorial, not a single factor. And there are many risk factors that increases the chances of diabetes also. Like if there is family history of diabetes, if somebody is putting weight and obese, if somebody is more than 30 years and if somebody is having sedentary life, there are some modifiable risk factor and some are non-modifiable risk factor. When you go and talk about the pathophysiology of diabetes, type 2 diabetes is simply because of the dysregulation of glucose homeostasis. This is characterized by persistent hyperglycemia and there is impaired beta cell function and the insulin resistance. When we look the theory of diabetes, there is like initially it was thought only there will be three causes, like there will be impaired insulin secretion, there will be increased glucose, hepatic glucose production and the decreased glucose uptake. These are the main three reasons for diabetes. But now the theory of diabetes has changed. Now from the trimmed period, it became the omnious octet. That means there are 8 major theories for the development of the type 2 diabetes. But minimum, like there is increased glucagon secretion, impaired insulin secretion, decreased incretin effect, increased lipolysis, increased glucose reabsorption from the kidney, decreased glucose uptake from the muscle, and there are neurotransmitter dysfunction, and there is increased hepatic glucose phosphorylation. These are the main 8 causes for development of type 2 diabetes. So the paradigm is changing from trivariate to omniate octet. With this, how we diagnose the diabetes? If HbA1c is more than 6.5 with impaired fasting glucose of more than 126, and if we do the OGTT and if it is more than 200, we'll label the patient as diabetes. And if the patient has borderline like HbA1c 5.6 and 6.2, it is pre-diabetes. There are different types of diabetes. At least there are 4 types of diabetes. But usually we talk about the type 1 and type 2. Type 2, more than 90-95%. Type 1 is around 5 to 10%. And there are some special diabetes like gestational diabetes that is related to the pregnancy, and there are specific type of diabetes which is related with the immune reaction, monogenic, there is exocrine pancreas disease, and some drug-induced and the chemical-induced. The volume of the diabetes that I said is type 2 is the major volume. How the patient with diabetes presents, the presentation of the diabetes is variable. Patient simply presents with fatigue. The patient will have increased urination, excessive thirst, blurring of vision, and the patient may present with different type of complication like skin infection, diabetic retinopathy. The patient might present with the heart attack or heart disease, liver disease, kidney disease, and atherosclerotic cardiovascular disease. As we all know, diabetes is the multi-system disease, and it is because of the metabolic dysfunction, and that significantly increase heart disease, stroke, eye disease, kidney disease, and peripheral vascular disease that I already told. And in every 10 seconds, one person dies from the diabetes-related complication. That means in every 10 seconds, 2 person is getting diabetes, and every 10 seconds, 1 person is dying because of the diabetic complication. This will show what is the diabetes burden, what is the risks of diabetes to the general population. Actually, when we are treating the diabetes, the goal should be, SbA1c should be less than 7. This is given by the ADA and European American Society of Diabetes. And if we analyze the data from the very developed country like USA, still around 50% of patients will have more than 7% SbA1c. This shows that even the patient is getting treatment, diabetes is not controlled properly. So the management of diabetes needs multiple approach like drug therapy, exercise, dietary, surgery, and there are like the better will be the prevention of the diabetes. When there is modifiable risk factor, we should, as far as possible, we should act to prevent the diabetes. So there will be interlocking ideas. So we need to ask the patient or in the population diabetic education, nutrition education, and the exercise. If we ask these things to the public and if they follow, they will definitely modify their risk factors, even if they have some non-modifiable risk factor. The other thing in the management of diabetes is the financial issue, especially the countries like low to middle income countries. Because of the medical expenses, and after getting disease, there will be lost productivity. So there will be a big financial impact also. When we are talking about the management of diabetes, my assigned topics will be the very novel therapeutics. So I'm not going to go detail of any other conventional treatment, but this is worth to mention when there are two breakthrough trials, DCCT and UKPDS. When we were medical students, at that time we heard this trial, and still these two trials are the main trials, and we are treating most of the patients according to these trials. And the newer therapy modality came after these two trials, like medical nutrition therapy, physical activity, monitoring of the blood sugar, add and go on medication, and self-management education. And for this, we need to have internists like nutritionists, specialists, endocrinologists, and diabetes educator. So we should give the comprehensive care for the diabetes because this is the multi-system involvement disease. When you talk about the medical nutrition therapy, there are different recommendations. The main thing is we should be conscious about our daily dietary plan. When we talk about the drug, I'm not talking about the conventional drug. I'm talking about this SGLT2 inhibitor, GLP-1 receptor antagonist, dual GPI and GLP-1 and receptor antagonist, and the another drug is DPP-4 inhibitors. These are the drugs. They are said to be the neo drugs, and they are the novel therapeutics in the management of the diabetes. When you see the evolution of the anti-diabetic medication in the early 90s, the starvation diet and the traditional remedies were the main treatment for the diabetes. Now there are many things came up to 2022 or 2025. When you talk about the evolution of the insulin, insulin also developed from the early 90s to now the insulin therapy, now the smart insulin, now it came the smart insulin. When we look the different site of action of this OHA, these are the liver, muscle, neurotransmitter, pancreas, kidney, gastrointestine, lipid, and all. Why we need this novel approach? Glucose homeostasis is more than just a beta cell function. Current therapy has limitation and remain unmet the needs and requirement for a new therapy. So role of new therapy like SCL2, GLP, diabetic technology, and novel approach to insulin therapy are ought to mention here. When you talk about the novel therapy, this blood glucose monitoring, continuous glucose monitoring, insulin pen, this continuous subcutaneous insulin infusion, and automated insulin delivery. Most of the country, they are using this, especially it is very difficult for the country like our low to medium income country because of the cost and the affordability. And there are novel approaches for the insulin therapy. Also, there is availability of the inhaled insulin, buccal insulin, but there also the research is going on for the oral insulin because the insulin is so unstable. So when we give oral, but the research is going on to get this oral insulin also. There are different type of new drugs. I said these drugs is extracted from the bark of the apple tree, and it meets the SCL1 and SCL2. Definitely that drugs is the gliflozin or flazones, and this considers the promising therapy that target to treat the diabetes and the obesity. It inhibits both SCLT1 and SCLT2. SCLT1 primarily in the GIT and SCL2 in the, that express primarily in the renal tubules. And there are new developed drugs like DAPA, impagliflozin, they are already available in the market, and the other drugs are under trial. And this SCL2 inhibitor lowers the glycemia independently, even if there is insulin resistance and beta cell dysfunction, because the mechanism of SCL2 inhibition is there is no reabsorption of the glucose from the renal tubules. This is the normal healthy individuals, 90% glucose is absorbed in the proximal convoluted tubule by SCLT1 and 10% from SCLT1. And when there is hyperglycemia, there is spillage of the glucose from the kidney. And the mechanism of this SGLT inhibitor is it will inhibit the SGLT receptor in the proximal tubules, so that even if the patient has hyperglycemia, if we give, this is not working. And another drug is type 2, for the type 2 diabetes is the, this exenatide. This is the incretin mimickers, and this is usually extracted from the Gila monster that stimulates the insulin production, and delays the gastric emptying. And so, impaired incretin action is another ought to mention here, because we should redefine the pathophysiology of diabetes mellitus. If this incretin is impaired, the chances of pre-diabetes and type 2 diabetes more. So newer targets are on this. I'm not going to go detail of this GLP-1 receptor antagonist. This is a novel drug. It's coming up, and most of the endocrinologists, they prefer this drug because it has multiple site of action, and finally, the patient will have controlled blood sugar, they will have controlled obesity, they will have control or suppression of the cancer, and the patient will be healthy, even in the young, middle age, or in the old age also. This GLP one receptor antagonists are indicated. And when we talk about the diabetic technology, blood sugar monitoring is available. This CGM is also available in the most of the center and the most of the community in our part of the world also. And we are supplying the insulin pen for delivering the insulin. And another is the continuous subcutaneous insulin infusion. This is very difficult in our part of the world because of the cost factor and the education of our patients. And another is the artificial pancreas device system. In this system, there will be continuous monitoring of the glucose, and that signal is delivered to the insulin device, and insulin device will give intermittent insulin. So it's a type of physiological, simulate the physiological stimulation of the pancreas and delivery of the insulin. So we call it the artificial pancreas device system. And the other newer target for diabetes in 2025 are inhibitor of 11 beta hydroxysteroid dehydrogenase, glucokinase activator, pancreatic G protein coupled fatty acid receptor antagonist, glucagon receptor antagonist, and metabolic inhibitors. And when we talk about these inhibitors of 11 beta hydroxysteroid dehydrogenase, this reduces the glucocorticoid effect in the liver and the fat, finally decrease gluconeogenesis, insulin sensitivity, and there will be well glycemic control. When we talk about the glucokinase activator, if we give this glucokinase, there will be release of the insulin. This is under investigation. And the newer target for the pancreatic G protein coupled fatty acid receptor antagonist, these are also under trial. And pancreatic G another newer target is the glucagon receptor antagonist. If we give this glucagon receptor antagonist, there will definitely decrease hyperglycemia, oxidative stress, and diabetes complication. And finally, non-steroidal mineralocorticoid receptor antagonist, phenidone, associated with the patient with heart failure with preserved ejection fraction. And there are other novel targets for the anti-diabetic. They are under research. And the newer target therapy is the gene therapy and the stem cell therapy for the management of diabetes. And this is upcoming. So management of the diabetes mellitus is not just a simple, it's a multiple approaches needed. So glucose management, blood sugar pressure management, lipid management, and agents with cardiovascular and kidney benefits. Last not least, we also need to be focused on the food care. Diabetes and the diabetic food are the very notorious. Once the diabetic patient will get this diabetic food, it will be very difficult to control, and they usually land with the amputation. To summarize my presentation, diabetes is the multi-system disease. It's a metabolic disease. And the management is like conservative. The old is still the gold one. And physical therapy, diabetic education, old drug therapy, new drug therapy, diabetic technology, reduction in the risk management, and reduction in complication. So when we are managing the diabetes, we should weigh the risks and the benefit. Always, whatever treatment we are giving, we always should weigh the risks and benefit. If the risk is more, then we need to treat. If the benefit, if the risk is more, then we should think of the giving the drug. If the benefit is more, we should go ahead. Some diabetic drugs are really very notorious. They can give rise to acute renal failure, cardiovascular effect, and other things. So thank you. Thank you for listening my presentation, and welcome to Nepal. In first slide, I also said, I am from the place where the Buddha was born, and Lumini is the birthplace of the Lord Buddha. Thank you. Thank you, Sri Lanka College of Internal Medicine, for providing this opportunity. Thank you.
Thank you very much, Dr. Ratnamani. Please join with us. The question will be asked at the end of the symposium. I will hand over the mic to introduce the next speaker.
Our next speaker is again from another sister country of South Asia, and he's from Bangladesh. Professor Sohail Mohammed Arafat, MBBS, FCS, MRCP. He's Professor, Department of Internal Medicine, Bangladesh Medical University, Dhaka, Bangladesh. And he'll be talking to us an interesting topic, AI in healthcare, applications in the South Asian context. Over to Professor Arfat.
Thank you very much for your kind introduction, respected chairpersons, learned audience, and guests. And I would also like to thank the organizers to invite me to be here as a part of Global Forum session. I'm Arafat, I'm the chairman of Association of Physicians of Bangladesh. Okay, next move on our topic. You know that in this era, the artificial intelligence is covering every aspect of our lives. So I will go through some topics like fundamentals of AI, the practical applications, which is changing the medicine, risks and ethics regarding AIs, AI in South Asian context challenges and way forward. Since the inception of human civilization, there's so many revolutionary changes happens in industrial sectors. Back in end of 70s, the invention of steam engine, end of 80s, another revolution, the innovations of electricity have changed our lives, have shaped our lives. But real digital liberation starts at the end of around 1980s with the discovery of computers, softwares, so many gadgets. And that revolution is still going on. At this age of 2025, the blurring of margin of human lives and technology. You can see we are living in the seas of robotics, seeing the 3D pictures, so on, and on top of that, nanotechnology and artificial intelligence. So this is my topic today, is just a little bit back in regarding the fundamentals of AI. What is AI? All of us know. It is just, it mimics the cognitive intelligence of human being in the form of problem solving, reasoning, learning, as well as decision making. So all the faculties of human brain, what we usually deals, the AI is doing the same thing on their own. We know our brain is very complicated. We have got 86 billion neurons and more than 100 trillion networks. And with this so complicated networks, we can learn from our surroundings by repeated stimulation so that our brain can process any information which comes through and take a good decision out of that. This AI is a broad term, very broad. All of us, I guess all of us, you know, who are living in this era, that phase by phase that's been developed. The first the conception of AI came in 1950 by Dr. Alan Turing. Later on, that came like a conference in Dartmouth Hospital, Dartmouth and conference in the University of Dartmouth in US. John McCarthy has coined the term of AI, that was artificial intelligence. Since then, there's a winter period. Later on, that's get a hype around 2000, year 2000, so that gradually we have developed so many phases of AI. On the process of that, machine learning, deep learning, generative learning, GPT, and GPT-4 and ChatGPT at the end of 2023, we got it in our hands. That is our initial conference from which the artificial intelligence was started as a term in nomenclature, and there was a big conference of scientists related to this AIs. So my point of interest is generative AI. You know, the generative AI is something that almost mimics human brain. That is a part of the AI systems which can create new original content like text, voice, images, audios, videos from the learning patterns from the vast data set which was fed to him, fed to this intelligence system, and they can generate outputs that mimic human brain-like activity. And the generative AI, how that develops, the similarly other AI is like a lot of input. There should be a lot of input from human, like data, that emails, information, journals, everything they're giving, they go through some processes, machine learning, then neural networks, deep learning, so on. And ultimately, they produce these outputs in the form of large language modeling, or GPTs in this way. But this is not the end. That is the repeatedly refined and the enforcement of this learning of the generative AI from human backup. Say, for example, if we ask a generative AI to make a case scenario of a 25-year-old gentleman with the symptoms of tuberculosis with lab diagnosis and treatments, they will retrieve the data from all the information they have got, and they will pattern this scenario and make a case outcome like a real-life scenario on the tuberculosis patients of 25 years with the treatment and management like this. But thing is that to get a good output from generative AI, we need a good input of data that is, should be of very good qualities. So this is the way, if from the CT scan, what has been shown here, that multiple CT scan, thousands of CT scan has been needed to train the machine to get, through machine learning, to get the information, what sort of changes they might expect. They go by layer, ultimately machine learning from deep learning, then go to the interneural network within the, AI systems. Ultimately, they could differentiate what is, in fact, what is hemorrhage, what is tumor. So you need lots of information to feed the machines or AI systems. Let's look at this. There's a bone check GPT, which can identify fracture risks. To develop this simple software, they have been trained with 20 textbooks of bone biology, 20 clinical guidelines, pivotal clinical trials, and 200 common question answers. Ultimately, getting those information and feeding the system, they ultimately they could produce this AI to detect the fractures like bone check GPT. But how that is playing the important role in our healthcare system? If we start in the patients in the clinical scenarios, we are all doctors, so physicians, we have to start the patients at a very initial stage regarding the, asymptomatic patients. Even we can stop. AI can have a role in screening out, in detection, early surveillance systems and awareness system. Even when it's diagnosed, it can help to find out the specific symptom. We expect the science, they can give input to the clinicians. That sort of GPTs are there. When patient disease suspected, they can play a very active role in planning the appropriate diagnosis, in planning appropriate tools. Also, they can help in making the diagnosis easier. Not only that, during treatment, they can give the special protocol management of the patients, how we should treat. They can also guide the physician. So that is all steps of patient management from beginning prevention to the death. The AI has an important role which they can play in future. Not only patient-related, they have got good role in administrative setups, like administrative workflow, nursing management, electronic health records. They can also play a very good role in epidemiological surveillance system, and so on. Even drug discovery is also an important part of the healthcare system where the AIs can play their roles. Just have a look in this slides. This is how they are helping the clinicians make the life easier for the patients also. This is a fracture risk assessment. If we see that they have developed a shape-based algorithm, from the simple X-ray. By using this software, this AI, from simple X-ray, we can detect the asymptomatic vertebral fractures or fractures of osteoporotic patients. You look at this patient, there's a data of 50 patients along with 90 with fracture and 94 without fracture. The SBA could detect almost with the sensitivity 100% and 62% with specific, if we say regarding specificity. At vertebral levels, it is around 80% sensitivity and specificity. What the importance of this? Because we are overburdened physicians. So if SBA can detect from simple X-ray that the fragility risks or fracture risks, they will reduce the work burden of radiologists. Also very good help to the patients to prevent further falls, prevent fractures. And interestingly, they take only 0.3 seconds to assess a single X-ray. So that will be so much, smart approach to deal with the patient with fracture risks. I also want to mention another big study that has been done in Netherlands. They are the routine breast screening program. There are around 42,000 mammography were assessed, and they were followed up. Initially, it was validated by 2 radiologists, human being, and another was validated 1 human reader as well as 1 AI. So when they saw that when the single person is assessing the things with another help of a single AI, there's high rate of detection of breast cancer. You can see from this double human reading, get 2.9%, but when that is accommodated with AI information or AI input, that raised to 5%. So giving the benefit of increase in the sensitivity 8.4%. So that could help the early detection of breast cancer and regarding the morbidity and mortality of those unfortunate women. It also can play a role, the psychiatry, In psychiatry, it is very difficult sometimes to go to the doctor to discuss your personal issues, some social stigmata. So AI also have a good role, can have a good role in communicating with the psychiatric patients, including schizophrenia spectrum disorders, depressive disorders, social anxiety disorders. There's a meta-analysis they have discussed, they have analyzed at least more than 10 studies, but till now, though it can be light in the future, but till now it is not that much so much evidence proved. But still we can hope that we'll come up with some sort of solution for our psychiatric department patients. Not only screening, they can also predict the future risks of getting a disease, what will be the disease burden. This is a Delphi-2M model that is all Google DeepMind, one sort of Google DeepMind project. This software, this AI, was used to detect the future disease risks what a patient might have in future. They've studied around 0.4 million, that means 4.4 million UK biobanks patients was analyzed with Delphi-2M model. And from that analysis, they could predict what will be the outcome. In practical life, what we do, to assess the risks, we get the patient history, family history, comorbidities like this. So if machines are fed with this sort of information, they could detect, they could predict how many percent of people might, this person might develop heart disease at the end of 20 years, or cancer, or diabetes. So if we can plan for future, what might be health effect if we can use this software appropriately. So in screening, in diagnosing, in treating, also in predicting the future risks, we can say that AI will be a good player to detect those issues. Nonetheless, it is over-the-counter, so many wearables we are using, like you can see that we have got gadgets, we have got mobile apps, or so on, and it is a huge impact on the day-to-day life and general people. And the problem lies with that. For general people, when it comes to use the general mobile apps, that creates some pressure with the physicians. And it's a huge business, though there is no regulations. So in personal life, in physicians, all contexts, we are facing a huge impact of AIs in our practice. As I said, it can play in diagnosis screening, it can be helpful in risk prediction, even drugs discovery and clinical support. When we get some treatment to the patient, we can take help from the ChatGPT or the open evidences so that we can appropriate. You have to understand, it is ethical, should be ethically bound because we have to give the best treatment to our patients. For everyone, we can't keep every information updated. But if we can take help from this sort of supports, we will be able to give the best treatment to for the best interest of the patients. So sometimes it might be that that will be mandatory for each physician to use AI to give treatment to the patients. So a lot of opportunities are there. Trials are more effective, already said the pathology quantification, the MRIs, that pathological slides that could diagnose breast cancer, effective risk assessment also there. But there are also some caveats that GIGO, I'm coming to the next point, next slide, that low quality evidence and over trust and scaling. If we say what is GIGO, GIGO means garbage in, garbage out. That is a well-known term in the AI world. Because if you give the poor quality data, outcome will be poor. So we can expect a good outcome of feeding the machine with the poor quality information. In the internet, there's lots of disinformations, misinformations, so a lot of questionable quality. So that should be ensured that good quality data should be available to feed the machines. Another issue, descaling. Descaling is, you can see this is a study from Poland. They have seen that when the patients, physicians are well dependent on the AI, sometimes the reverse might happen. They have compared the physician's skill before and after using AI. There's significant reduction of the skills of the physician to detect the colonic adenoma. So we have to be aware of that. Our skills should not be compromised as well, though we should take the help from AIs. It's not free of risks. Other parts, risks of the patient is there. Ineffective models might be AI failure, might misuse of the AIs. lack of accountability, who will be responsible for if anything happens to the bad to the patient, the machine itself, AI or the patient or physician, that's an issue. There's an issue of data privacy, confidentiality, also the quality of it called to de-skill the workforce, what I've said before. So these are the definitely very important issues we have to taken care of. For this reason, WHO has developed a governance on 6-point principles to reduce the risks of the AI regarding ethical issues. That should protect the human autonomy. Human must be the final decision of taking the health care of the patient, and informed consent should be there. They have to promote the well-being and safety and in public interest. That should be the best interest of the patient. We have to be transparent, ensure transparency, how the information AI is being given, how they are taking the decision. That should be explainable, and that should be well transparent to the users from point of view. They have to be responsible. When some harm happens, who will be responsible? There's a clear idea is that stakeholders, not the AI system, must bear the responsibility of the user and outcomes. If harm occurs, there must be mechanisms to readdress. So there should be readdress of those affected. Ensure inclusive equity and promote AI that is responsible, sustainable. You have to regularly update the AI information regularly. Now, our points is the South Asian context. Why it is different? Because you have 1/3 of the population of the world is residing in this part of small area of the world. There's a lot of communicable diseases. NCDs are mostly rampant here. And there's very variation of the health service providing in the urban and rural and suburban areas, availability of doctors, the rapid growth of data, images like this, and limited health workers. You can see in this part of the world, per 1,000 doctors per 1,000 persons are only less than 1. Majority of the country, there is less than 1. So we can understand that so scarce manpower to give a huge number of population regarding health services impossible almost. So we can use the AI as a force multiplier. To bridge the gap, AI is maybe a solution. AI promises because AI can provide us more work with less force. But still there is a lot of obstacles, lack of financial constraints. AI is very costly, regular update, regular subscription. There's lack of high quality data. I'm not sure about the Sri Lanka, but this part of the world, data keeping is really poor. There's no electronic data records. There's already paper-based data and poorly, constructed. So, but for AI, developing AI locally, you need good data. Lack of infrastructure, lack of AI expert and data science specialist, expensive, GPU need to buy high cloud computing from abroad. Lack of regulations, so data, how the data will be, data conversion will be managed, how data will be collected. We need a very good regulation. Still there is none. Infrastructure gaps, lack of existing infrastructure to accommodate the AI systems. Electricity, internet is still is a problem in this part of the world. And patient safety, I've said that AI has been developed for the focusing the developed part of the world. That might not be applicable in this part. Lack of digital literacy might lead to inappropriate use and improper conclusion of the AI informations, and over-dependence definitely by non-medical person, and lack of clinical oversight compromise patient safety. On the end of that, workforce with the doctors, with the physicians, sometimes lack of trust in the AI system, and fear of replacement is still there. So there is a lot of issues that should be addressed in this part of the world. But I want to share a few scenarios of this country, of this happening here. That is one of these, the Nirama is a software for breast cancer screening in India that is non-invasive risk assessment of machine with machine intelligence. So that is thermal imaging, no radiation, nothing is there. They're just captured by thermal camera from breast temperature, ultimately analyzed by thermolytics, and ultimately that can give some idea regarding the breast neoplasm. Very small center is there, no issue of privacy, everything is fine. That can be done every corner of the world, every corner of the country where it is not good without any good communication, road communication, rail communication. Just we can see the result. Out of 15,000 screening, the 460 had suspected lesion in the breast on the basis of thermolytics, and ultimately 27 women was confirmed diagnosis, which would be missed if we go for conventional mammography and other ways. In Bangladesh, we are using TB for tuberculosis, TB rampant in this part of the world. Almost 380,000 people are suffering tuberculosis, but unfortunately, 20% is undiagnosed. So we have started screening of tuberculosis with a very small digital camera, digital X-ray, which is portable, can be brought everywhere in the corner, and we can analyze can be analyzed by AI, that is computer-assisted diagnosis. So that was, we screened 231,000 people of suspected or exposed to tuberculosis patients. Ultimately, 42,000 was found to have some radiological abnormalities. And after the conformity test and clinical suspicion, more than 3,500 people are confirmed diagnosis bacteriologically, and 5,000 around was diagnosed as a case of on a clinical basis. So this huge number of population would be missed if we could not afford them to this sort of diagnostic amenities using AI. So that is a huge public impact. Other parts of the world of this kind of fewer softwares are used in the practice, but still have got a lot of challenges. Main challenges is the biasness. All data are prepared from the Western, so that's called white guy problem, because their data, their genetics, everything is fed by them, so that might not be appropriate for our context. So we have to be careful about this using data in our population. Even psychiatric, there's a publication there, there's some problem with the biasness in psychiatric patient management. So what we can do, we have to develop local data sets, open access medical data repositories, encourage public and public-private partnerships, inclusion of AI in medical curriculum. We have to train our students, medical students, physicians about the AIs, how to use. Need to low cost and high impact AI tools suitable. Need increasing collaboration between clinicians, data scientists, and policymakers. Also make a common regional cooperation among scientists, physicians, and other resources to make a common platform to make some AI tools which might be applicable for this part of the world. So AI, we should not be afraid of AI. AI promises to help us to do more with the less. I'd like to acknowledge my contribution from my colleagues who are working with me. At the end, I like to say AI will not replace doctors, but doctors who use AI will replace those who don't, and they will fly higher with colors. Thank you, everyone. Thank you, audience. Thank you.
Thank you very much, Professor Arfat, for that timely and very informative lecture on AI. And it's in this part of the world, it's really difficult for us to bridge the gap between the resources and with available new development. So the symposium is open for discussion. With the time available, we can, you all can ask 1 or 2 questions.
Yes, please.
Andrew Seaton from the United Kingdom. What a great symposium, so thank you very much. My question really is just to the last speaker from Bangladesh, to ask you about your assessment of the kind of risk of the environmental impact of AI, the water that's needed to sort of cool these supercomputers, the huge amounts of electricity that are required to kind of power these questions that we're now answering on our phone, and so particularly for, I guess, the impact on the environmental impact in your part of the world in South Asia, and whether that's a concern.
Sorry, I couldn't get you the question clearly. Can I
say it again?
Yeah, sorry.
No, it was a comment on the environmental impact of AI. AI requires a huge amount of electricity and water to sort of cool these supercomputers that are doing all the analysis.
All right, thank you. Thank you, definitely. Regarding AIs, it have got it have got role in every aspects of human life which is involved. It might be person, it may be social, it may be culture, it may be environmental. Definitely, I guess the AI has got, we can take the help of AIs in developing some sort of customized program to see the impacts of environments for this part of the world. You know, that environments is totally different from your country. In UK is regarding the sun exposure, regarding the floods, national calamities and winters. So definitely that have got role on, yeah.
Yeah, I have a question. So what are the clinical responsibilities, ethical responsibilities of a clinician when we are using AI for our clinical decision making? So what are the ethical obligations, ethical responsibilities?
Okay, very good questions. This is a huge gray area, you know. Regarding the ethical issues, still in the world, there's unsolicited, I should say. WHO has issued 6-point principles, which I have shown that should be equity, confidentiality, then autonomy, then validity, explainability, a lot of issues. FDA also has some recommendations, but unfortunately, thousands, lakhs and hundreds, thousands of AI is being developed. They are not validated. To validate an AI, we need randomized controlled trial. Because what is the purpose of AI? That is the benefit of the patient's health regarding healthcare. So their RCTs still is not possible. This is huge costly. So regarding ethical concept, I think the autonomy is the number one. Patient's consent is or sometimes not taken. Their data might be misused or used by unauthorized like insurance companies, third parties. That is one of the important area we should take care of that. Number three, their effect on the human health, that should be validated, because when drugs are invented, there's some authority, FDA in Bangladesh, your country also authority who will give the license. But for AI related, the safety, there's no authority like this of this world. So that is really ethical issue, is a very important concern regarding this AI issue.
Okay, thank you very much. In the interest of the time, we'll conclude the symposium. So I'll invite my co-chair to present the certificate of appreciation. Yeah. So Professor Ratnamani.